today. We're going to discuss some of the myths behind surgery and its degree of difficulty. We'll discuss some of the indications and discuss the data as it exists, or discuss some of the larger, well put together studies, because part of the confusion in all this is that everybody bases it based on their very last patient, their very last collection of patients, making it very difficult for families that are in the process of evaluating this for the first time, deciding what they're going to do. Now we're going to talk a little bit about the definition of spasticity, because I do think that some of our surgical choices, at least in neurosurgery, are defined by what's going on with each individual patient. Then we'll go through sort of how we do Baclofen pumps, how we do selective dorsal rhizotomies, and discuss some of the outcomes as we sort of go through this. Now, spasticity, as Dr. Brunstrom had pointed out, is a velocity-dependent increase in tonic stretch reflex. It's one component of it is one component of motor neuron disease, and examples are multiple, where there can be either spinal cord injury, stroke, ALS, CP, and MS as one of many causes for the evidence of spasticity. It can be divided both into spinal as well as cerebral causes. This is important because you can use some of these treatments for other types of spasticity, as long as you're getting your diagnosis correctly. Now, the reason this is important is because, as they point out, dystonia can also be a component of this disease. These intermittent, often painful, twisting, repetitive muscle spasms with contraction of both agonist and antagonist muscles can cause difficulty because, to give you, for instance, your rhizotomy is not going to do a lot for this particular type of movement. So which means that in order to discuss with your physicians, with your interdisciplinary team, what the most appropriate treatment in this situation is going to be, is you need to have a very good understanding of what, or as good an understanding as can be, of what's happening and what the different components of the movement disorders are. Well, cerebral palsy is a common cause of disability in children. It has a lifetime cost that is significant, and it has a lifetime cost that can be significant based on whatever treatment you end up choosing. Meaning you have your bracing, you have your Baclofen pump refills, you have your continued casting that you have to do through these, for these patients as they get older. Now, CP is considered a non-progressive condition. However, declining motor ability with age is evident, especially during middle to late teenage years. We generally think of these patients that motor function plateaus in that 6 to 9 month range group, making it important to really determine, and base your evidence or design your studies as to what the natural history of these patients that have CP, what their natural history is actually in the absence of any surgical treatment. They have progressive joint, muscular, and skeletal deformities. They develop before reaching skeletal maturity, making it important to treat these patients as they move up into early adulthood. Now, one of the biggest problems for defining what we do in this kind of situation is the standardization. I mean, I can go collect the last 10 patients that I put Baclofen pumps in and collect them saying I did okay. But how do you determine, in the context of multiple different studies and a large patient population, how you're doing relative to everybody else? You first standardize what you end up treating. And we do this by definition by the creation of different scales which have been developed, including the Ashford scale, discussing spasticity as you can see from there, grades 1 through grade 5, up to its effects parts, rigid, inflection, and extension. This is important because you begin to grade your improvements in your spasticity by using this particular type of scale. The other one is the gross motor functional classification system. I won't spend too much time on this other than say it begins to define your outcomes. Whereas you're able to improve your outcomes in these various patients depending on your surgical treatments. You need to be able to standardize whether you're doing it in North Carolina or you're doing it in Columbus, Ohio. You need to have a very standardized way of defining what your patients are doing and how their outcomes are appearing after you intervene surgically. Now, the goals of treatment are especially important. And before I talk about each of these patients, when I was in St. Louis, I would sit down with Dr. Brunstrom discussing what are the goals of treatment. What are you seeking to improve? Are you seeking to improve the motor activities of daily living? Are you seeking to improve the simple ability to dress patients? And that can, are you talking about decreasing orthopedic deformities? Are you seeking to create somebody to go from a wheelchair to walking? I don't know if you can actually say that, but you need to set realistic expectations for each of the patients based on the data as it exists, and not the last patient that you ended up treating. Now, the nice thing about CP is a lot of these patients are in the very mildly affected category. There are, however, a large number of patients that are in the grades 4 and 5 category with a lot of other significant comorbidities, which makes it important in deciding your surgical treatment. You ever tried, unless you've ever tried to put a Baclofen pump into somebody that has a curve of 110 degrees, it's quite difficult in that situation. And you want surgeons that are capable of doing it or have done it in that kind of situation, because it gets quite difficult when they've undergone spinal fusion for progressive scoliosis trying to place a Baclofen pump. Now, as was pointed out earlier in our earlier talk, these surgical treatments vary based on age. Age, when you get for basic developmental purposes, the fact that these kids cannot have a Baclofen pump when they're really young, they end up treating them, as you correctly point out, with both botulinum toxin and a variety of other non-surgical treatments. They can get brace, they can get a variety of other, they get physical therapy. Surgery treatments doesn't start in most centers up until ages 4 on up. Some of the centers that do a lot of selective dorsal rhizotomies will start doing them in ages 4, even downwards of ages 3 on up into a variety of years, in hopes of avoiding the pain and the progressive orthopedic deformities that you end up seeing as these children get older. Now, many treatments, however, this is sort of the depressing slide. Many treatments of spasticity were inadequately evaluated prior to being adopted, meaning there was non-regimented ways of looking at outcomes, non-regimented ways of defining who gets physical therapy afterwards, who gets physical therapy before, and how do you end up choosing and defining your patients and what their motor function is. Reliable outcome measures with the help of physicians like Dr. Brunswick are being developed and are basically being used to create large studies, including several large retrospective studies that are being currently created to really define what surgeons are doing and how to measure outcomes, including instrumented gait analysis, and defining which is actually the better treatment for what patient population. Now, with this, let's talk a little bit about Baclofen pump. Now, Baclofen pump is indicated for spasticity, in my opinion, in 2 groups: ambulatory with poor leg strength. It's also in non-ambulatory patients with severe spasticity, with the goal is to facilitate care. Meaning that when you compare this versus selective dorsal rhizotomies in patients that are severe spastic quadriplegic, you're really not going to really do a very good job with these patients, and the families are not going to be happy with the outcome. In addition, you're also not going to be really happy with a large movement, if a large component of the movement disorders is dystonia. These patients are not going to be affected by selective dorsal rhizotomies. And when you sort of piece this out for the families, you really talk about them as to where the spasticity is and what the dystonia component of the movement disorders, and how Baclofen pump or DBS stimulation, for that matter, would be a better situation in treating those patients. The spasticity needs to be for a significant amount of time, at least greater than 12 months. This is specifically important when you talk about spasticity in spinal cord injury or in patients that have had a traumatic brain injury. They often try oral drugs, or including Baclofen. If you have oral Baclofen and you have intolerable side effects, you may want to think twice about doing a Baclofen pump. Oftentimes we will do, at least in the present institution, we'll do intrathecal test doses. That can be variable depending on where you're from. In St. Louis, we very rarely did intrathecal test doses because that doesn't predispose somebody to having success with a Baclofen pump or not. Oftentimes, these kids can be ages greater than 4 years of age, but they have to be somewhat larger because they're, it's like having a hockey puck in the right lower quadrant when you end up putting a Baclofen pump in. The way we do this is we place a lumbar subarachnoid catheter, and we're able to actually tip. The tip is variable, but it really makes up to C7, C1, depending on what the functional component of these patients are. It's secured to the lumbodorsal fascia, and then it's tunneled to a subcutaneous pocket. And for those of you considering the Baclofen pump, we always put it first-time placement, and unless there's some functional component, we always put it on the right side, because as Dr. Brunstrom pointed out, nutrition for these particular patients is equally important. And the reason we don't put it on the left side is that often interferes with the feeding tube in that situation. So we try to keep the two distinct and always, always, always place it on the right lower quadrant. Variable use of the pouch is used to encase the pump. It's really, I don't particularly use it, but there are a number of other institutions that do. Make sure to also ensure the location is not underneath the incision, because oftentimes it's a mechanical device and it can erode through the incision and can erode through the skin, leading to a variety of complications. These are what they look like. This is one of the synchromet pumps, and as you can see, it is a hockey pump. And you do end up being able to see it and that's one of the downsides of placing Baclofen pumps. You're able to program it, and you have a variety of bolus dosing, intermittent, continuous, a variety of dosing patterns you can do depending on the way the patient does look at the pump, and the way the patient does respond to Baclofen. The middle does demonstrate how we end up securing it from the dorsal fashion, and we're able to place most of these with just a simple IV or needle access into the intrathecal space and place. And the only time where any of them happen to open is when they've had previous spinal fusions. That makes it excessively difficult, or oftentimes you have to do out the bony fusion mass and end up placing it that way. But what you end up doing is then, placing this is like a video game where you end up driving under fluoroscopy up to the C7, T1 interspace, and you're able to do that for pretty much every patient that I'm able to place, because, if you get it in the right position. However, I like to tell the residents that I've seen many, many of these. This is an axial non-contrast image showing that the catheter can, complications are frequent in the placement of the Baclofen pump. But what you need to evaluate is that you get spinal fluid back when you replace it, because this is an image taken from a Baclofen pump placed in an outside institution where they clearly did not even make the catheter placed into the Baclofen pump. And the family, the came said the Baclofen pump's really not working. And you could tell based on the x-ray and then obviously the follow-up CT, the thing didn't work. The thing didn't work because it wasn't in the right spot. So obviously, with placing it in the correct spot with return of spontaneous spinal fluid, you're able to fix. This gets at to what I'm talking about is the downsides of the Baclofen pump. It is, while not a permanent procedure for management of spasticity, is a procedure that is fraught with complications, meaning pump under infusion, catheter breaking problems, occlusion, kinks, wound pocket erosion, incisional pain, infection, and these complications can manifest themselves up to disconnection, breakage, cut upward. There's, you see some of the literature, they talk about catheter tip migration or dislodgement upwards. It can manage between 30 to 40%. It can have some form of complication when they end up, all of which, when they end up having a Baclofen pump place. That's the downside. That's a large series. Just show it out there, and I deal with all the patients and showing them all the data, and even give them the studies when they come talk to me about whether we're going to talk about Baclofen pump or talk about dorsal rhizotomy. All of these things can be managed. It's not to frighten you. It means that you have to come and see the physicians in a more continuous manner that ends up avoiding this, or deal with centers that have large multidisciplinary teams that are capable of managing and diagnosing these problems when they do come up. Baclofen withdrawal syndrome is also an important cause by, and what it is fever, hallucinations, rebound spasticity. This is equally important because if you're going to place the Baclofen pump, you need to recognize what happens is you start infusing intrathecal Baclofen. You need to recognize what Baclofen withdrawal syndrome is, because this is a medical emergency. You need to figure if this does happen, either disconnection, malfunction of the pump, or whatever way you end up talking about it, this needs to be dealt with in a very significant, rapid manner, and you need to be able to deliver intrathecal Baclofen with the thought of delaying this and improving the patient's condition. Now let's talk talk a little bit about, in the next 10 to 20 minutes, let's talk a little bit about selective dorsal rhizotomy. How many have seen the St. Louis Facebook page or website? Okay, selective dorsal rhizotomy was first adopted in 1908 by Forrester. Davis Dorsals. They figured out that the guys that underwent this, that were suffering from this dorsal column disease, their spasticity went away. They began performing 45 operations, frequent complications. They were sectioning the complete dorsal nerve. What they found is they had muscle weakness, they had complete loss of proprioception, they had other things that were just inordinately wrong and inordinately more difficult for patients than the actual manifestations of spasticity. In the 1960s, they began recognizing that the division of only a fraction of the nerve roots contributed to spasticity. And they began just dividing a fraction of the nerve roots. This began being adopted by TS as well as Peacock in the 1980s. And they began identifying the nerve roots criteria through electrophysiology. Though the enthusiasm was tempered by concern about long-term effects, recognitions that large uncontrolled studies are capable of bias towards favorable outcomes. This is, unfortunately, part of the problem with this is we're still arguing about the exact indications for selective dorsal rhizotomies. However, there are large centers, say in St. Louis, that have not a large number of these that have excellent outcomes for the treatment of this particular disease through manifestations of selective dorsal rhizotomy. This is one of their things. This is how they end up treating patients or selecting patients with or selective dorsal rhizotomies. They talk about spasticity without significant ataxia or dystonia, the degree of ambulation with or without assisted devices. Currently, most patients grades 2 and 3. No injury to basal ganglia brainstem. Oftentimes, they will be getting MRIs. They have good stroke control, lower extremities that are anti-gravity strength, on clinical examination. No significant scoliosis, and at least 6 months after botulinum toxin injections, and at least 1 year after orthopedic surgery. They need to also, this is equally important, and because the physical therapy is equally important when you talk about dorsal rhizotomy. Now, I'll be honest with you, the procedure is not that hard. Equally important is the families that are able to participate in the physical therapy and the strengthening that undergoes afterwards. They go for at least 6 weeks in St. Louis. We end up doing 2 weeks of inpatient rehab. You go to Minneapolis, another large center, they will do almost 6 weeks of inpatient rehab. In the process of making these patients and strengthening these patients after the weakness that we see after taking that spasticity away. Patient selection is important. They are greater than 2 years of age. They have a history of premature birth. It's one of the most prime candidates who we end up selecting for selective dorsal rhizotomy. There should be no deterioration after preschool years. We talk about pre-op evaluations, including looking for lumbosacral spine, scoliosis, spondylolisthesis, or other congenital abnormalities, including tether spinal cord. We talk about gait analysis to verify the spastic hemiplegia and also determine whether there's no other dystonic component to the movement disorders. We also look for fixed orthopedic deformities because we're not going to fix that by taking the tone away. If they've got a contracture, that ain't going to go away, and that is still going to have to be dealt with by the orthopedic surgeons after the dorsal rhizotomy. We talk about partial deaugmentation of these nerve roots. Now, and I'm going to show you probably the best study that's been done is a meta-analysis showing all the randomized control trials that were done in dorsal rhizotomy. Partial deaugmentation works. You test the EMG nerve roots, you talk about the part modifications, the single-level laminectomies, minimally invasive, either 1 to 2 level laminectomies, and what you're able to do is see with ultrasound localization of the components. This is what we're looking for. The division here of the nerve roots is, what you can see is the arrow is pointing to the division between the dorsal and ventral nerve roots. You have to get to the very end of the components because that's how systematically you're able to identify the nerves that you can touch, the S2 nerve roots, versus the nerves that you can't touch, the S1 and above nerve roots, to relieve the spasticity from the feet all the way through the lower extremities. So you're able to get the most desirable outcome in the treatment of this selective dorsal rhizotomy. What we then end up doing is we then end up dividing up the nerve roots and placing These are all the dorsal nerve roots once they've been identified using electrophysiology. And the anatomy that we end up being able to see once we've located the very tip of the conus. Once this is accomplished, we then use our electrophysiology and are able to divide out the nerve roots and cut probably between 60 to 75%, meaning when you take large fiber bundles, you end up, this is how we end up positioning them for this selective dorsal rhizotomy, and this is from the Selective dorsal rhizotomy anatomy book, where this is the way he positions them, and he's able to place a legend between the ventral and dorsal nerve roots, and then we divide them out and are able to sexually as we go through. Now let's talk about the reason we did this versus doing the doing the multi-level laminectomies is there was to cut down the complications, improve the shorten the time that the patients are in the hospital. And really, I've seen it. I mean, we send patients home both in St. Louis and in Columbus within 5 days after surgery, or send them to rehab, as would be in our case. This is what we use. We use electrophysiologic response, and we're able to show that a differentiation between a variety of the nerve roots, and as we end up testing them, and we tend to section the nerve roots that are in the 3+ and 4+ range, because they're the ones that we theoretically believe are the ones that are contributing to the spasticity of these muscles. However, I should also point out that this is not a belief that is shared by everybody, because some centers believe that this bears no relationship to outcome in the selective dorsal rhizotomy, where I could get the same exact result if I just cut 60 to 75% of the dorsal nerve roots, as long as we identify the correct ones. It's, that's one of the current theories that is being argued amongst neurosurgeons that are doing selective dorsal rhizotomies. Now, this is our post-operative care, where we talk about post-ICU observation. We do analgesia, fentanyl infusions, or the placement of epidural catheters. We end up transferring them. Both CS and myself, we don't end up doing any ICU care. We convert to oral analgesia very quickly. We continue on flat bed rest. This is so we have very minimal problems with spinal fluid leaks. And ultimately, they're either discharged or variability or to rehab within 5 to 6 days after surgery. Some do 2 to 6 weeks of inpatient, others do 6 weeks of 5 days a week of outpatient rehab, depending on the family's ability to participate. And it becomes important when you're talking about having families that are traveling for long distances. Now, SDR causes a permanent decrease in spasticity. With sustained improvement in gain of spasticity, only some of the earlier studies did show it provided only a fraction of the nerve roots, and they said, well, it didn't work, and so obviously selective dorsal rhizotomy doesn't work. However, as the number of as some of the other studies have shown, there's direct proportionality between improvements in outcome, reduction in spasticity, and the amount of nerve roots that you end up dividing. Long-term benefits. There is several long-term studies out there on selective dorsal rhizotomies. Obviously, they are come a lot from St. Louis. They show there is an improvement there is less orthopedic surgery that is needed. There's also durable improvement in lower limb tone, gross motor, and performance of ADLs, leading to some to suggest that this is a long-term surgical procedure that can benefit patients up into early adulthood. Complications. In the interest of complete disclosure, complications include sensory disturbances, spinal instability. Spinal instability can, depending on who you read, occur in up to 10% of the patients. Though we have had, since going to 1 to 2 level laminectomies, we have had very few patients that have had evidence of spinal deformities. Paraplegia or incontinence, CSF infection. In practice, patchy sensory loss is the only one that you see on a consistent basis. And this patchy sensory loss does get better within the 1 to 2 weeks after surgery. They talk about improved ambulatory motor capabilities. We have the traditional check versus what TS has done in really championing the minimal approach, which are a variety of centers that he's trained to do across the country. This is probably the most, since I'm not going to show any of the single patient issues, but rather a meta-analysis of 3 randomized controlled trials for selective dorsal rhizotomies. This is important because these are the children both from Vancouver, Toronto, and Seattle, and as you can see, these studies were done a while ago in the late 1990s. And what it showed is these are the children that were done within each of these various centers. And what it showed very clearly is that selective dorsal rhizotomy does improve your spasticity, does reduce your spasticity, and does improve all of your gross motor function scores in each of these various studies. And what it does show is that they confirmed that an overall reduction in spasticity in SDR, this was particularly well controlled because they did both SDR with PT as well as PT alone and compared the two. Pooled results also confirmed that these results in improvement in motor function. A very well-designed study that showed that selective dorsal rhizotomy is a tool in the toolbox in managing the spasticity that these children have during the remainder of their lives. Other treatments for spasticity to include that there are multiple, to really get to the point that there are multiple tools within this toolbox, include the tendon release and lengthening that you heard a little bit about when they're talking about with botulinum toxins, osteotomies for contraction deformities, and other neurosurgical procedures have also been done, some historical, including neurectomies, intrathecal phenol or ethanol or DRES procedures, none of which are done anymore. The only one that's really talking about is that the use of DBS in patients with dystonia. Now, in summary, we'll talk a little bit about we'll sort of go through the main take-home points, and that tone reduction in CP is necessary, a statement that you can all agree with. Baclofen and selective dorsal rhizotomy are excellent options for spasticity treatment. These treatment choices need to be defined based on each of the particular types of movement disorders. We are still struggling with the kind of long-term studies and large volume studies that are really able to talk with patients about and families about what the exact percentages are of improvements that you can expect. I guess I'm here because I'm not a particular zealot about whether you need surgery or you avoid surgery at all costs. I tend to present these families, and I think our people in Columbus present these as each of the tools and try to discuss the data, the limitations as they exist, and how we're going to work towards studying and trying to improve the information that we can provide families in choosing each of the various treatment options. Now, what's pretty clear based on my personal opinion as well as and my experiences is that Baclofen pump is actually the best choice for patients with spastic quadriplegia and patients that have dystonia as a primary component of their cerebral palsy. Now, what this breaks down into is, very simply, these are the way that people are generally thinking about rhizotomy or Baclofen pump. They can talk about these as far as this is probably a lot of what most people are doing in who they're selecting for selective dorsal rhizotomies, going back to the more original, one of the original slides that I said. And as you can see, these are the patients that they generally, that depending on whether you're in Indiana or in St. Louis, you end up choosing a lot of these kinds of patients for Baclofen pumps as well. And as you can see, there's a lot of overlap or discussion about who's appropriate for each of these neurosurgical procedures, leading to the unfortunate conclusion that we still have a lot of work to do to decide which of these types of patients are best suited for each of their various treatment options. And with that, I want to thank you, Jan, for having me. And hopefully this was a little bit illustrative and as sort of limitations of the data and sort of what we do for both Baclofen pumps as well as dorsal rhizotomies. Thank you very much.